I'll be presenting the principles of wound healing outlined. Wound can be defined as a disruption in the structural and functional integrity of a tissue. Then wound healing is the process by which the living organism replaces damaged tissues with living tissues. Wound healing can also be defined as a series of stepwise overlapping physiological events that restores the structural and functional integrity of an injured tissue. In lower animals, it is by regeneration, while in man, it is imperfect with forced tissue replacement. So a little historical perspective, in the year 2000 BC, Sumerians used spiritual methods to heal wounds. And in the year 1650 BC, Egyptians differentiated infected wounds from non-infected wounds. In the year 1550 BC, Ebers Papyrus described use of lens, ointments, etc. for wound treatment. Then the Greeks described acute versus chronic wounds. And in the year 120 to 201 BC, Galen described the importance of moist environments to wound healing. Other people that made inputs in wound healing include Ignaz Semmelweis, Louis Pasteur, and Joseph Lister. Theology of wounds, there are several things that cause wounds, but they can be broadly grouped into mechanical agents, which include things like road traffic accidents, domestic accidents, assault, or chemical agents. The mechanical agents, these ones cause physical injury. Chemical agents, like strong acid and alkali, cause injury. Strong acid found to cause coagulative injury or necrosis, while alkali cause liquefactive process. Another etiology of wounds could be radiant energy, where you have things like atomic energy, like X-ray, or things like high voltage electricity, or extremes of temperature, like intense heat or cold. Could also be from pathogenic microorganisms like bacteria or fungi. And then another group, neoplasm. So classification of wounds. Wounds are classified using very different criteria. There is the classification based on whether it's an open or closed wound. And in closed wounds, you have wounds like contusion. Then in open wounds, you have puncture wounds, laceration wounds, penetrating wounds, perforation wounds, abrasions. Then there are avulsion or degloving wounds. The wounds can also be classified based on gloves contamination. And the American College of Surgeons determines 4 classes of wound based on level of contamination. These include the class 1, which are clean wounds, class 2, which are clean contaminated wounds, or class 3, contaminated wounds, and then class 4, dirty wounds. So class 1 wounds, that's the clean wounds, are those with no sign of inflammation and do not involve any breach of any hollow viscous. Examples include a simple herniatomy or a skin lump excision. Then class 2 surgeries, class 2 wounds rather, the clean contaminated, are surgeries involving the gastrointestinal, respiratory, or genitourinary tract, or removal of pins or wires, or gynecological procedures, as long as the surgeries are uncomplicated. Class 3 wounds, which are dirty wounds, they include gunshot wounds, knife blade wounds, or large amount of spillage from GI tract into the wound. Highly inflamed or infected tissue around surgical wounds. The class 4 is dirty wounds or dirty infected wounds, which include those with foreign objects lodged in the wound. Like maybe when you have a bullet wound and then there are debris or foreign objects lodged in the wound, or farmyard wounds, or wounds already exposed to pus or fecal matter. And there is a classification of wounds based on duration, where you have acute wounds when the wound is less than 6 weeks in duration, and then chronic wounds when the wound has exceeded 6 weeks. Then there's also a classification of wounds based on degree of tissue devitalization. And Rank and Wakefield classified wounds into tidy wounds, indeterminate wounds, and untidy wounds. So now the phases of wound healing. Wound healing is broadly divided into 3 phases for convenience, even though there is some level of overlap among 3 phases. So the first phase is the inflammatory phase, which lasts for about 3 days to 1 week. Then the next phase, the proliferative phase, which begins by the third day, lasts for about 2 to 4 weeks. Then the remodeling phase, which begins from the 2 to 4 weeks after injury. This is organogram that shows the different phases of wound healing and the responses mounted by the body in the event of a wound. And you can see the phases, the broad 3 phases on the right side, the inflammatory that is reactive, the proliferative, regenerative, and the maturation phase, which is the remodeling phase. And we see that there are further splits. The inflammatory phase contains or is made up of the points at which the body tries to stop bleeding, and then the chemotaxis, and then the epithelial migration, and then there's proliferation, then there's maturation, then there's a contraction of the wound site, then there's scarring, then the remodeling of the scar. So these are the different phases of the wound. So the inflammatory phase is initiated by stimulus such as physical injury, gene antibody complexes, or infection. So hemostatic mechanism is the first thing that is triggered, which includes the initial vasoconstriction of vessels and followed by platelet adhesion and aggregation. So platelets then release vasodilatory agents to increase vascular permeability. And these vasodilatory agents include serotonin, histamine, bradykinin, prostaglandins. Platelets also release growth factors like platelet-derived growth factor, transforming growth factor beta, insulin-like growth factor 1, adhesive glycoproteins, and fibronectins. So this is a diagram that shows response of the endothelium in the effects of injury. And the first one shows the normal permeability of the capillary, and then the second diagram below shows the response, the increased permeability, which allows fluid seep out of the blood vessel and also allows migration of substances that aid in wound healing. So the first thing that happens is neutrophil activation. It has a number of steps. And the first one is the rolling. The neutrophil keeps rolling, and the essence of this rolling is such that receptors on the surface of the neutrophil, or that there are substances on the surface of the neutrophil that bind receptors on the endothelial membrane. So as it rolls, it keeps on rolling, and rolling is just like a conformational change. It keeps rolling until it binds to those receptors. And we can see after the rolling comes the shedding of the L-selectin, and then there is adhesion. The neutrophil adheres to the vessel, and by virtue of the increased permeability, the diapedesis occur where the neutrophil squeezes itself out through the spaces. The substances that have already been used, like the serotonin and bradykinin, that already mediate the increased permeability. Other substances like complement factor C5, activated factors, and chemokines, the histamine, the prostaglandins, and leukotrienes, and further release lipopolysaccharides, interleukin-1, and tumor necrosis factors, ultimately release activating substances. So this is just an attempt for it to further amass more cells of the immune system to the site of injury. So this is a diagram showing the fibrin plug, and is in the inflammatory phase. You can see the clot that has been formed by the clotting pathway in a bid to prevent the bleeding. You can see neutrophils in the clot, you can see macrophage, you can see primary platelet plug that was initially formed that would now be strengthened by fibrin. And then we can see other substances released like the insulin-like growth factor, the platelet-derived growth factor, the fibroblast, and vascular endothelial-derived growth factor, other substances that play a role in this inflammatory phase. A brief explanation of the inflammatory phase. Neutrophils are mobilized by chemoattractants to the site of the wound, like interleukin-1, the proteases, and hydrolases. The neutrophils now perform phagocytic function and produce more cytokines that perpetuates the wound healing process. And the chief regulatory cell is the tissue macrophage, which produces plethora of cytokines, as shown in the tables below. So macrophages are now attracted by monocyte chemoattractant protein 1. It consists of two simultaneous processes epithelialization, angiogenesis, and fibroplasia. So epithelialization predominates in primary wound healing, while angiogenesis and fibroplasia is more prominent in secondary wound healing. Epithelialization process involves proliferation and differentiation of basal cells at the wound edges. Then there's migration of the syncytial layer towards the center of the wound by amoeboid movement due to loss of contact inhibition. There's also formation of epithelial spur, which are columns of cells which grow downward. So once the cells meet in the center, contact inhibition is restored. The epithelialization process is facilitated by endothelial growth factor, transforming growth factor, as well as interaction between the integrin molecules and the extracellular matrix. So the fibroplasia now involves fibroblasts, which are attracted by macrophage secreted chemoattractants. Fibroblasts in turn now secrete glycosaminoglycans, hyaluronic acid, laminin, fibronectin, collagen, with the subsequent formation of ground substance like the foundation. Type 3 production, collagen production predominates in the early phase of wound healing. Angiogenesis is the formation of new blood vessels. Keep in mind, all these processes are occurring simultaneously. So angiogenesis is the formation of new blood vessels. It involves the endothelial cells degrading the basement membrane, then division of the migration endothelial cells, resulting in tubule or lumen formation. So these interactions are modulated by certain substances, PCAM, metalloproteases, FGF, angiogenin, nitric oxide, lactic acid, and tissue hypoxia. So these are some of the substances that play a role in the formation of new blood vessels in the proliferative phase of wound healing. In the maturation or remodeling phase, wound contraction is mediated by activated fibroblasts called myofibroblasts, which are present throughout the wound. So they initiate centripetal forces via interaction with the extracellular matrix, which is all around the circumference of the wound. There is a sort of force, impulling force, that tends to contract and close up the wound. So fibroblast population decreases, dense capillary network regresses. The wound strength increases rapidly in 1 to 6 weeks. So there is cross-linking of the collagen fibers, and vitamin C is important in the hydroxylation of collagen monomers formed. Type 1 collagen production now predominates as against the type 3 that was seen in the earlier phase. This is just a graphical representation of the distribution of cells in wound healing in the different stages of wound healing. So you see that in the acute phase, in the inflammation phase, neutrophils are the predominant cells. They rise, the levels of neutrophils rise and peak at about day 2 and then start declining. The next one is followed by macrophages, which we've learned play a central role in wound healing. Its levels to plateau at about the 3rd day and then gradually declines up until the 10th day, where it now maintains a steady state, not rising and not decreasing. So the fibroblasts are the next. The green line shows the fibroblasts and the level of increase, and shows that the plateau at about the 5th or 6th day, and afterwards the levels decline. And then the next cells are the lymphocytes, plateau around the 6th day. So you see that the neutrophils have a sharper rise compared to every other cell. And this shows the content of the extracellular matrix at different stages of wound healing. In the inflammation stage, more fibronectin content compared to the collagen. Collagen 1 starts at inflammation phase and continues to rise up until the maturation phase, which gives an insight also to the wound breaking strength. The higher the number of days, the higher the wound breaking strength. So this is just a table that shows the important cytokines. The cytokines that play important roles in wound healing and their cell source, where they are secreted from, both the pro-inflammatory cytokines and the anti-inflammatory cytokines. And then also shows the activity, what they do in response to their secretion. Important growth factors, the platelet-derived growth factor, the transforming growth factor beta, and the epidermal growth factor, transforming growth factor, fibroblast growth factor, keratinocyte growth factor, insulin-like growth factor, and the vascular endothelial cell growth factor. The numerous functions in wound healing. Now we'll talk about the factors that affect wound healing. They are broadly divided into the local or systemic factors. So the systemic factors include things like infection, because when there is an ongoing infection in the body, the rate of wound healing is slowed down. Ischemia. For wound healing to occur, inflammation has to occur. And then we know that inflammation is a response of the vascularized tissue to insult. So which means for wound healing to occur, the tissue needs to be vascularized, blood needs to flow to be able to carry some of these inflammatory and anti-inflammatory substances that mediate wound healing. If there is ischemia, it's difficult for these substances to get access to the place where the wound is in order to initiate wound healing. People with diabetes mellitus have poor wound healing and delayed wound healing. And then another factor is ionizing radiation, depending on the level of people were exposed. So advanced aging occurs, the rate of wound healing or the efficiency of wound healing is reduced. Malnutrition and vitamin deficiency, vitamin A and C, then mineral deficiencies like minerals like zinc and iron, drugs like doxorubicin, corticoids. So the local factors that affect wound healing include radiation, foreign bodies. Another factor is immobilization or trauma, local infection, blood supply. The principles of wound care include timely debridement, because if it's a wound and there are dead or devitalized tissues, we expect the wound healing in that place to be optimal. So those dead or devitalized tissues need to be removed as much as possible, and the place irrigated for wound healing to take place. Prophylaxis and antibiotics analgesia is also important. So asepsis, gentle tissue handling or dressings, hemostasis, wound closure. It could be primary closure, delayed primary closure, or secondary closure. Mobilization. Adjuncts to wound care, that added modality or added therapy, added modalities that would help or would favor wound healing. And first of all, include nutritional support, the hyperbaric oxygen therapy of recombinant growth factors, negative pressure wound therapy, dermal matrix, engineered skin, or cultured epidermal autografts. In as much as there is normal wound healing, abnormal wound healing can also occur. And this is where you see things like keloids and hypertrophic scars. And it's just excessive deposition of collagen and in a haphazard manner. This now increases expression of mast cells within the wound. Keloids are commoner in blacks and Asians than in Caucasians. And the keloids grow beyond the margin of the original wound. Now, another abnormal wound healing would be chronic wound healing wounds, where there is increased proteinases, M2, 8, and 9, increased interleukin 1, interleukin 6, and tumor necrosis factor 8. And this is seen in pressure ulcers and chronic leg ulcers. Difference between keloids and hypertrophic scars. Keloid has racial predilection, commoner in dark skin. There are no racial predilections for hypertrophic scars. It has keloids have familial tendencies. Hypertrophic scars do not have familial tendencies. Keloids occur more frequently in certain anatomic sites. Hypertrophic scars can occur in any injured part of the body. Keloids grow beyond the original margin of the wound. Hypertrophic scars do not grow beyond the original margin of the wound, but gives rise to elevated scars. Keloids require multimodal therapy, but hypertrophic scars can be treated by monotherapy. So keloids progressively increase in size, but hypertrophic scars regress in size with time. Complications of wound healing are things like infection. Dyschromia is another complication. Dyschromia just means even coloration or even pigmentation around the area. So you see some areas hyperpigmented, you see some areas hypopigmented. Implantation cysts, marginal ulcer, unstable scars, keloids and hypertrophic scars we talked about, and they are contractures and cicatrization. In conclusion, wound healing in man is essentially by fibrous tissue replacement. Progressive understanding of the physiological and molecular mechanisms underlying wound healing will hopefully lead to better modulation of the healing process. Thank you very much. These are my references.
Polymorphonuclear cells, neutrophils, which migrate. So you have migration, you have diapedesis, metastasis. So these various stages that are involved in the inflammatory phase, are impaired in uncontrolled diabetes. So you have abnormal migration, abnormal diabetes, abnormal chemotaxis, abnormal phagocytosis, all in the inflammatory phase as a result of uncontrolled diabetes. So that is how uncontrolled diabetes can affect wound healing. So you now have a prolonged inflammatory phase. Even sometimes you never have an inflammatory phase at all, because the markers that are required for the inflammatory cells that are required for the inflammatory phase are abnormal or deformed. This prolongs inflammatory phase and also prolongs wound healing by aging. The other pathways is due to microangiopathic abnormalities, vasculopathy that occurs with aging, from atherosclerosis. So with atherosclerosis, the amount of perfusion to soft tissues that provides the inflammatory cells that are required for wound healing is reduced. So you have ischemia as you grow older from microangiopathic changes, atherosclerosis. That is on one hand. The second hand is as you grow older, the risk of comorbidities from diabetes, from steroid use, which I have already explained how diabetes causes impairments in wound healing. So those are the pathways. First one is macroangiopathic changes that occurs with aging, from atherosclerosis, which reduce blood supply to periphery, reduce blood supply to tissues, and this further reduces, or prolongs wound healing. The other thing again I mentioned is as you age, comorbidities, diabetes, the use of steroids also have their own effects on wound healing.
Vitamin C is a cofactor in the synthesis of collagen. It helps in the hydroxylation of proline and lysine that are components of collagen synthesis. So if there's absence of vitamin C, there's going to be a disruption of that hydroxylation process that happens. So the collagens that will be produced will not be very efficient for wound healing.
Yes. So they act as a cofactor for the hydroxylation. Yes. Proline in the proliferative phase.
Transcutaneous oxygen measurement. The minimum needed for adequate wound healing is 25 millimeters of mercury. Infection decreases the oxygen pressure in the wound. Also, if there is ischemia, it also decreases the oxygen tension in the wound. Those are the reasons why you have poor wound healing, where you have all those things, because the wound remains too long in the inflammatory phase, so it doesn't progress. Okay. Then also, vitamin A. Vitamin A counteracts the effect of steroids. Steroid inhibits the synthesis of collagen from fibroblasts. It also inhibits the movement of macrophages and other cells into the wound. So that's what steroid. And eventually decreases the tensile strength of the wound.
Aging will affect wound healing in all the phases, of wound healing: inflammatory phase, proliferative phase, and even the maturation phase. So primary closure is healing. Is when you want to close a wound, there's no excess tissue loss, minimum, and you are closing the wound before granulation tissue is formed. Delayed primary wound closure, you are afraid that maybe there's edema or infection, you suspect, but you allow it for like 3 days or 72 hours to allow edema settle. And if there's any infection, by then it should have showed itself. So if there's no, you now close it. That's delayed primary closure. But secondary closure is the wound that was already infected. You do all those things, then subsequently you close the wound. But usually granulation tissue would have been present, and then it's usually after 10 to 14 days. But most of the time you do secondary closure for wounds that are highly infected. You allow infection to settle before you do that. So the healing that occurs in a primary closed wound is healing by primary intention. You get, if you start hearing for the secondary closure or healing by secondary intention, people, if you don't mention that granulation tissue was already formed, some people will not be happy. The healing by secondary intention, either healing by granulation tissue formed or after it has cleaned out, usually by that 10 to 14 days, you would have had some granulation tissue being formed. The healing by tertiary intention is the healing that occurred in a wound that is closed, in the delayed primarily closed wound. The factors affecting wound healing, you omitted genetic factors like Ehlers-Danlos syndrome, progeria, cutis laxa, that will make their wounds not to heal. In the management of wound care, there's this time concept currently that we use. Remember that this wound you are talking about is broad. It's acute wound, maybe acute wound or chronic wound, so it's broad. So the time concept, T is for tissue. tissue debridement. I is to control infection or inflammation. M is moisture balance. You don't want the wound, you don't want too much, you don't want the wound to be dehydrated. I don't want excessive exudate. You just want it to be balanced. And then edge control. The wounds will heal well. Meted the clinical classification of wound healing. Classification is the wound in extension phase. Is it in transition phase when the infection, if it's active, is already reducing? Is it in the healing phase, in the stage of chronicity? If you're able to talk about this clinical classification of the wound, it will also help you when you are managing your wound. For instance, the wound in extension phase where there's active inflammation, you may want to increase frequency of dressings, you may want to give IV antibiotics. A wound in healing phase, you may just want to dress once in a week. You may not want to put any harsh agent. Your normal saline may just be okay. So that will influence your choice of dressing agent, what you do to take care of the wound.
I just want to make a clarification. You know, there are two separate topics. If a person is asked to present principles of wound healing, it's different from present principles of wound care or present principles of wound care and management or current concepts in the management of wound care and wound management. So I noticed that, he actually combined principles of wound healing, and then towards the end, he also added some principles of wound care and management. So you have to be clear whenever you're giving a topic to present. And that is why during the discussion, I could hear, and then they were also talking about preoperative, intraoperative, postoperative principles. That actually is applicable to wound care and management. So it's separate from this presentation, which is mainly principles of wound healing. We didn't talk about wound healing in special areas. Specifically, when you're going to talk about that, you have to mention, those special areas like the GIT, the healing in GIT mucosa, healing in blood vessels, healing in cartilage, healing in tendon, healing in bone, even fetal wound healing. Why should we talk about healing in fetal tissues?
They heal without scar because of the transforming growth factor beta that they have in them. So they have scarless wound healing.
Yeah, so that is why when you're talking about the future advances, advances in wound healing, vis-a-vis how they have an impact in your wound care and your wound management, you mention, as a small note at the end there, in advances in wound healing, studies being undertaken to investigate more about how fetal tissues, how they heal, down to the molecular level, wound care products, wound care dressings. So what's the difference between healing, repair, and regeneration?
Healing means the restoration of function and structure of an injured part of the body.
Regeneration, there's replacement of tissues like for like. That is, the exact cells and the exact tissues are being replaced for regeneration.
Yes, so it's the ideal, isn't it?
Yes, ma'am.
Yes, if it's like replacement of tissue, like for like, with little or, no loss in function. How about repair?
Repair is an attempt to restore function, although replacement with fibrosis rather than tissue or rather than similar tissue.
Yeah, so that's the difference between healing and repair. In healing, there's an attempt by the tissue to restore that integrity in the structure and in the function. While in repair, there is replacement of that tissue with collagen, and then there is some associated loss of function. So those are just the differences. Did you come across any other terminology for the definition of, another terminology that's used in the place of inflammatory phase of wound healing? Okay, sometimes the inflammatory phase of wound healing is referred to as the lag phase. And then, that's the reason why it's termed that is because the wound strength doesn't return immediately. So sometimes you see in texts that the inflammatory phase is termed as the lag phase, so that you won't be confused. I know that in those days in MCQs, they used to ask us about pro-inflammatory cytokines and anti-inflammatory cytokines. Can you mention some of those pro-inflammatory cytokines?
Pro-inflammatory cytokines, we can have interleukin-1, interleukin-6, tumor necrosis factor.
Yes, you can also have interleukin-8, and then some of those growth factors can be the platelet-derived growth factor, isn't it? Yes. The TGF, beta, alpha, and IGF. So those are some of the pro-inflammatory cytokines. How about the anti-inflammatory cytokines?
The anti-inflammatory cytokines are interleukin-10, interleukin-4, interleukin-2 is one of them.
Interleukin 11 and
Yes,
13.
yes.
What is granulation tissue?
The new blood vessels and then the fibroblasts are formed then. Consists of the blood vessels and the new collagen laid down. That's it.
So it's a kind of replacement, isn't it, for the normal dermis? And it usually becomes a scar, isn't it, in the remodeling phase of the wound healing. So you usually have this dense network of blood vessels, capillaries, fibroblasts, macrophages, and also just some randomly arranged collagen fibers. In the proliferative phase, there are some specific processes that take place there. Can you just mention them? 1, 2, 3, 4.
Epithelialization, angiogenesis, and fibroplasia. And they occur simultaneously. I don't know if there's a fourth one.
Yes, fibroplasia, angiogenesis. There's also some wound contraction, isn't it? Epithelialization,
Yes, ma'am.
isn't it? Proliferation. Okay then.
Surgeons are in the business of creating wounds, and it's important for us to understand the various stages. What are the factors that can help, accelerate wounds and delay our wounds when we create them.